Healthcare and Hospitals Association webinar to celebrate NAIDOC Week. Happy NAIDOC Week. With support from Hesta, we're pleased to be able to present this discussion about getting better healthcare for Aboriginal and Torres Strait Islander people when they go to hospitals. I'm Chris Burke. I'm the Strategic Programs Director here at the Australian Healthcare and Hospitals Association. I'm a Camilla fellow here on Ngunnawal country here in Canberra. And it's my great pleasure to be your host today. In recognition of this year's NAIDOC Week theme, always was, always will be. AHHA recognises Aboriginal and Torres Strait Islander as being the traditional owners of Australia for over 65,000 years, recognising that continuing connection to land, to water and culture. And as I said, I'm here on the land of the Ngunnawal people in Canberra, and I pay my respects to their elders, both past, present and future, and to all the countries out there where you are today. I think we've got over 100 people online. It's been a very popular webinar for us, and there were another 120 people, I think it was, on the waiting list. That's amazing. They'll all be given a copy to see this link afterwards when we'll have it recorded up for YouTube. So it will be available later for you as well. We would like to also acknowledge the generous support of Hesta, who are sponsoring this webinar, and we're joined today by Hesta's Chief Partnership Officer, Neil Saxton, who'd like to say a few words. Over to you, Neil.
Thank you, Chris. And Hesta and AHHA have a strong partnership, and it's an honour and absolute privilege to support today's event. Can I add my welcome to the wonderful panellists and all of the participants of the webinar. And we at Hesta applaud AHHA for organising this important event to coincide with NAIDOC Week. I also acknowledge the traditional owners of the land on where we meet. I'm on the land of the Wathaurong people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. I extend that respect to all Aboriginal and Torres Strait Islander people here today. This always was and always will be Aboriginal land. This is an important topic to be discussing during NAIDOC Week, better healthcare for hospitals for Aboriginal and Torres Strait Islander people. And at Hesta, one way we see this is through the actions of a number of our Hesta Award winners. Our 2018 Nurse of the Year, Gail Yarran from Western Australia. Gail is a Balladong and Wajak woman living on Noongar country in Western Australia, where she was once laughed at by her classmates at primary school when she confessed to having a dream to want to be a nurse. But after 50 years of resilience and strength, her colleagues now to refer to her simply as the bridge for her continuing efforts to weave together the two worlds of mainstream health and Indigenous culture. Our 2019 Midwife of the Year, Tracy Stevens from Victoria. Tracy developed the Bub-Up Bag, which is a new initiative to ensure Aboriginal expecting mothers and their families have resources and information they need during and after pregnancy. All Aboriginal women who engage with Monash Women's are offered a Bub-Up Bag, as well as support from Tracy and the team. The bag acts as a great conversation starter within the Women's and Newborn Service and aims to create a culturally aware and safe environment within the maternity departments. And our 2020 Midwife of the Year, Cassandra Ness from Queensland. We're a Gold Coast hospital. They're providing culturally safe care and equity of access, which is leading to better health outcomes for Aboriginal and Torres Strait Islanders. Cassandra's main focus is producing a service that is culturally safe, because as Cassandra says, as soon as you do that, that's how you contribute to closing the gap and improving experiences. Our vision at Hesta is for a respectful, confident and equitable Australia. Through our commitment to reconciliation, Hesta can be part of supporting real and lasting change in our organisation, the superannuation industry and the broader health and community services sector. Our Reconciliation Action Plan recognises the role that Hesta, the superannuation industry and our members play in our national reconciliation journey. This role requires us to better support, engage and partner with Aboriginal and Torres Strait Islander communities. It also requires the ongoing education and engagement of the superannuation sector. We are committed to building community partnerships grounded in respect and work towards increasing confidence with Aboriginal and Torres Strait Islander people. We advocate for equity outcomes between non-Aboriginal and Aboriginal people. In part, it's what leads us here today to support this really wonderful forum. Thank you again and enjoy the webinar, and back to you, Chris.
Thank you, Neil, and thank you for those wonderful stories of excellence and capability by Aboriginal and Torres Strait Islander people working in health. It's always an inspiration to us when we hear these stories of people who are doing great things. Today's webinar will discuss the latest research from Australia and North America on how hospitals can deliver better care for Aboriginal and Torres Strait Islander people and their communities and their families. After the three presentations, we'll have a short Q&A. So if you've got any questions, please enter them in the Q&A function at the bottom of your screen, and we'll get to them at the end of the presentations. So our presenters today will include, and I'll just go through the three presenters and introduce them all together, and then I shall turn it over to Alyssa, who is the first presenter. Our first presenter will be Alyssa Elvidge, a researcher and PhD candidate with the University of Newcastle School of Medicine and Public Health, where she has worked to develop an empirically validated cultural safety framework for New South Wales hospitals. Then we'll have Dr. Raglan Maddox. Raglan's a Marawa clan from Papua New Guinea man with a PhD and an MBH, Master of Public Health, and he's a fellow and study director of the Tackling Indigenous Smoking Evaluation at the National Centre for Epidemiology and Public Health at the Australian National University. Raglan's program of research has focused on developing population-based Indigenous health info systems using community-driven processes. And then we'll finish up with Ray Marnie. Dr. Ray Marnie is a descendant of the Bidjara people of Central West Queensland and is a senior research scientist with the eHealth Research Centre at the CSIRO. Ray has adjunct academic appointments at the University of Queensland and at QUT, and is a member of the expert advisor panel for the MRFF Mission for Cardiovascular Health. Ray's research background includes cardiovascular health disease, patient journey, health information, data quality, e-health, mHealth, and culturally safe care and racism. So over to you to kick us off there, please, Alyssa.
Thanks, Chris. Here we go. So before I start, I'd like to acknowledge that I'm on the unceded lands of the Pambalong clan of the Awabakal Nation, who are the custodians of the land that I'm on today at the Callaghan campus of the University of Newcastle. I'd like to pay my respects to elders past and present, and I recognise their continuing connection to culture, the land and waters that surround us. So today I'm going to talk to you about my PhD research, which, as Chris said, developed an Aboriginal cultural safety framework for New South Wales hospitals. I'm going to begin by giving you a really brief overview of the literature. I'll talk about some of my methods, and I'll present just a bit of a snapshot of the findings from my research. So racism takes place everywhere in our society, including in the health system. I know in my own research from interviews with hospital staff and patients that racism still occurs frequently in New South Wales hospitals. The accounts of racism that I observed in my study were varied, from private conversations among staff in the tea room to overt forms of verbal abuse directed towards Aboriginal staff and patients. Experiencing racism can have a significant impact that isn't limited to the people who are directly subjected to it. It also has larger flow-on effects to families, communities, and society as a whole. At the individual level, racism has a negative impact on a person's emotional, psychological, and physical well-being. At the interpersonal level, racism creates distrust, conflict, and reduced social participation. The experiences of racism in the health system result in access barriers, with many people delaying seeking medical assistance and avoiding health services altogether. There's also a significant body of evidence demonstrating that there are disparities in the quality of care experienced by Aboriginal patients that are the result of widespread institutional racism. These disparities in the quality of care remain after adjusting for a range of demographic and clinical confounders. Racism and a lack of cultural safety in hospitals are key drivers of these disparities. Cultural safety came out of New Zealand in the late 1980s, where it was initially defined as an environment which is safe for people, where there's no assault, challenge, or denial of their identity, of who they are and what they need. Therefore, cultural safety encompasses a critical consciousness where healthcare professionals and organisations need to recognise that institutional racism exists and then engage proactively in strategies to dismantle racism and enhance cultural safety. Whether or not a service is culturally safe is ultimately determined by the patient, and this differs from cultural competence approaches that are assessed by the staff or the organisations themselves. And as you saw from that screenshot on my second slide, cultural safety is gaining traction with several policies that advocate for increased cultural safety. However, very few of these policies define cultural safety or how hospitals should implement these policies. Up until recently, there were no empirical indicators that measure cultural safety from the Aboriginal patient perspective. And this is what led to my PhD research, which developed a cultural safety framework for New South Wales hospitals. So my study used a mixed methods approach, starting with a series of semi-structured interviews with hospital staff that examined how individual staff interpreted these policies and how or if these policies translated into practice in real life. So for this, I conducted 50 semi-structured interviews with hospital staff from a range of different roles, including executive level positions, clinicians, allied health, administrative and service support staff. I analysed the transcripts using applied thematic analysis, where I identified 3 key themes. And these themes were doing cultural safety, identifying culturally unsafe practices, and structure versus agency. So I'm going to talk a little bit about the last 2 themes, and these are some quotes from the hospital staff interviews. They are de-identified as well. As you can see from these quotes, many staff described a conflict between cultural safety and what some clinicians feel that they're able to do within the structural restrictions of the health system. Some staff recounted instances where they had to bend the rules to provide culturally safe care, and you can see that captured in Nelson's quote, which is up the top there. There was this ongoing tension between how staff interpreted the policies and used their discretionary power to either support or impede culturally safe practices. Other staff talked about either witnessing or experiencing racism firsthand. There were also many clinical staff that talked about what I describe as cultural blindness, where they claimed that they don't see culture or race because they treat everybody the same. This claim of cultural blindness is problematic, and it also represents an interesting set of assumptions. The first is that we treat everybody in the same way, and you can see from the literature that I provided at the start, the evidence suggests otherwise. The second assumption is that culture is not important. Again, we know this is not the case, and that culturally responsive care is necessary to achieve high quality healthcare. And finally, this ideology of cultural blindness is used to discredit the reality of racism, because it's impossible for one to acknowledge racism or reflect or respond to it if one denies that race exists. By denying this reality of racism, it is held in place by protecting the internal biases of individuals who claim to be blind, affirming themselves as non-judgmental and non-racist. Now let's have a look at Mary Ann's quote down the bottom there. Her comments highlight many of the common racist stereotypes that health workers have about Aboriginal patients. In particular, that health disparities are caused by poor lifestyle choices. And that completely disregards the systemic issues of inequality and racism. Consistently, these narratives are expressed through covert conversations in which they're predominantly shared with non-Indigenous colleagues using code words, stereotypes, and discourse. These casual backroom conversations, more often than not, are expressed behind closed doors where they can remain hidden and unchallenged. The second arm of the study aimed to develop a measure of cultural safety from the Aboriginal patient perspective using a survey. The survey design was based on the key dimensions of cultural safety that were identified through stakeholder consultations and also the literature. These questions were asked on a sliding scale to allow for statistical analysis. So we used both targeted and opportunistic recruitment methods, including social media. And at the end, there were a little over 400 surveys collected. And of those, 316 were suitable for exploratory factor analysis. Overall, the results showed that the survey was successful in developing a robust measurement model of cultural safety, as the analysis demonstrated adequate levels of both internal and external domain consistency. So in addition to those standard survey questions asked on the sliding scale, there were also two open-ended questions that asked patients what it was about their time in hospital that either made them feel safe or unsafe. So these quotes on the slide are just a very small snapshot of those patient responses. Many of the patients had similar stories that talked about being judged by staff, experiencing racism, poor communication, and a general lack of support when it came to culture and families. For example, one participant talked about feeling a sense of mistrust with hospital staff and his reluctance to identify as Indigenous. Others described experiencing racism and a lack of support from staff. One patient described her experiences after the birth of her baby, where she said, "They spoke down to me and my family, and it made me feel anxious about asking questions. They didn't understand that I needed my mum there. I'm a first-time mum, my baby was sick, and I was scared. They asked my mum to leave." These responses were not just isolated examples, quite the opposite. The same stories and themes of racism, a lack of cultural respect, and compromised quality of care were repeated over and over again, regardless of the hospital's site, location, or department. Whilst there are several policies that recommend creating culturally safe health services that are free from racism, there is still a significant divergence between guiding principles, policy recommendations, and what occurs in institutions at both the organisational level and during service provision. There is a need to critically reflect on what it is about our health system that continues to widen the gap and reproduce these patterns of health inequality. The cumulative effect of culturally unsafe care, experience of racism, manifest disregard and ambivalence from mainstream health services results in further barriers to reducing health disparities. The aim of my research is to respond to the current gaps between the evidence, policy, and practice by producing an empirically validated scale that measures cultural safety from the Aboriginal patient perspective, that forms part of a larger cultural safety framework for New South Wales hospitals. Ultimately, my work is about dismantling institutional racism and making health services accountable to the communities that they serve. I'd like to take this opportunity to thank my supervisors, and in particular, Professor Yin Paradies, the hospital staff who participated, and most of all, the hospital patients who took the time to share their stories. Without them, none of this work would have been possible.
Thank you, Alyssa, for your presentation. That was fabulous, and we shall move on to a Q&A a little bit later for you, but now we're going to hear from Dr. Raglan Maddox. Over to you, Raglan.
Thanks, Chris. Hopefully you can see my screen. Before I begin, I also wanted to pay my respects to the traditional owners of the land. I'm also on Ngunnawal and Ngambri country, so pay my respect to elders past, present, and future. I really appreciate being able to speak after Elisa, and I think there's a lot of similarities in Australia that I sort of gleaned from my experience in North America, and specifically in Toronto, Canada, that I'll speak about today and try and touch on some of those similarities. As Chris mentioned in the introduction, I come from the Mottawa clan in Papua New Guinea, which is sort of just north of Australia, just on the other side of the Torres Strait, where there's some great fishing, and I encourage people to get there when they can. And the reason I talk about this is I think it's really important to self-locate. And when Papua New Guinea became independent, our family ended up sort of divided between Australia and Papua New Guinea, Milne Bay specifically. So on the right, I have a picture of my mother and my youngest uncle, and my mother, I should say, is 65 or 66 years of age, depending on her actual age or a birth certificate. And I raise this because I think it provides context for some of the challenges that we might face in a place where we do have universal healthcare. And the reason I talk about that is sometimes when we're going through administrative processes and paperwork, there are a lot of things and structural barriers that may be in place that can impede on that. And I think this is a relatively common challenge that many people face. So I did want to bring that to the attention. I was lucky enough to spend about 5 years in Turtle Island, or North America, based at the Well Living House, which is an action research centre focused on Indigenous infant, child and family health and wellbeing. And it's housed at St Michael's Hospital in Toronto, Canada's largest urban centre. And I've got a picture here of Jan Longboat, who was one of the council of grandparents while I was there. And so the reason I bring this up is because the Well Living House is co-governed by the hospital board, as well as a council of elders or a council of grandparents. And so you can see on the right-hand side of this image, the elders, the grandparents, Madeline Dion Stout and Carol Terry. And then on the left-hand side, you can see the medical board, so Art Slutsky, the VP of Research, and so on. And I think this is really important because it speaks about the leadership and the importance of leadership within the healthcare system and what that can do for changing culture or creating a culturally safe or fostering a culturally safe environment, or something that we strive towards. I was in North America during an interesting time. We had the Truth and Reconciliation Commission report that I'll speak about. We had President Trump voted in as president. We had a change in Canadian government with Prime Minister Trudeau voted in from a previously very conservative government. And so it was actually a real time of change, and in some ways a little bit of confusion. And I talk about this because I think there was a real awareness and discussion around reconciliation, or truth and reconciliation. I think that's really important and something that I think may resonate with some people here. And the Truth and Reconciliation Commission report spoke about colonisation and the ongoing impacts of colonisation that is continuing today, and went into detail and created space for Indigenous people, First Nations, Inuit and Métis people across Turtle Island to speak about those atrocities and what was defined as cultural genocide, or genocide where active policies were implemented to essentially kill the Indian. It was the sort of language that is used and described. And I think that's really important. So when we start to look at our healthcare system, even though it's a universal healthcare system, either in Australia and in Canada, these have significant implications on the way the healthcare system is built, on the way society functions and societal norms. And so I guess as a foundation, we have a head start in trying to understand the context for which we are providing services and client-centered care, and coming at things from a trauma-informed approach. And as Chris also mentioned, we're involved in developing Indigenous population health information systems. And one of the reasons for that was that Indigenous people were generally excluded from population health counts. So the census, for example, was seen to undercount the Indigenous, being First Nations, Inuit and Métis population, by about half. So in the city of Toronto, the population is about 2 to 4 times the size of that captured in the census. And that has significant health and wellbeing implications in terms of funding for programs, services, hospitals, the types of resources that hospitals put in for creating culturally safe care. And this is just an example of the way that I think the Truth and Reconciliation report sort of documents Canada's history, which is continuing today, but is sort of an example of how, when we produced a media release highlighting the undercount of the Indigenous population in the city of Toronto, the way that it might be portrayed in the media. And I know Elisa spoke about stereotypes and things like that, and I think this is a great example of that, and a very pointed one. So on the left-hand side of the screen, you can see the Star presented the very same media release as the one on the right-hand side, but said, a report says Indigenous people in Toronto are far more likely to be homeless, unemployed and hungry. And then on the right-hand side, we have an Indigenous journalist present exactly the same media release, but say, new report finds critical gap in data about Toronto's urban Indigenous community. And I think that's really important to sort of start to unpack our own prejudices and bias that comes out. And that's something that places like Canada and Australia with the universal healthcare system that indicate we are human rights based and that everyone has a right to healthcare. We need to start to look at the way this is framed and how it impacts our own views and behaviours, including within clinical settings. So the Well Living House had developed and was rolling out, and is still rolling out, a project called Reconciling Relationships. And essentially it's an RCT with three arms. It's got a 10-hour, 8-module training session looking at cultural safety. It has a 2-hour education system, and then it also has a time attention intervention. It also has, as part of this research program, developed their own implicit association test, similar to the Harvard one, or based off the Harvard one, with Indigenous and non-Indigenous clients to try and find out or highlight some of the implicit associations there. And then I guess I wouldn't be doing my job as an academic if I didn't provide some homework. But I think there are probably, before I get to that, I'll just touch on a couple of interesting myths that I thought might resonate with some people in Australia. One is that Indigenous people live across the country, not just in rural and remote locations, and that racism is pervasive across the country as well. So you can see the second point there, unmet health needs and discrimination by healthcare providers among Indigenous population in Toronto, Canada. In Canada, the majority of Indigenous people live in urban cities, in locations, and that might not be presented in the media. And I think that's really important to remember. And despite having infrastructure in those urban locations, it doesn't mean that they're free from discrimination or free from access to services or have better access to services. And in fact, this report that I've flagged up there on the screen, the Our Health Counts Toronto report, actually found that about 30% of Indigenous people, First Nations, Inuit and Métis people, experience discrimination by a healthcare provider. And of that 30%, they're 3 times more likely to have unmet healthcare needs than those that didn't experience discrimination by a healthcare worker. And I can go on and on about that, but I'll save you that one. The other one that occurred just before my time, and I know Yin Parodies was involved with some of the work with Janet Smiley and Billy Allen on this, was a Brian Sinclair inquest and reports around that. So unfortunately, Brian Sinclair passed away in an emergency department after spending 34 hours there waiting for services. And then even more recently, just earlier this month or late last month, Joyce Eschwash was racially abused by hospital staff as she lay dying, but had the ability and the strength in those last couple of minutes to actually record the abuse and mistreatment of her in that time. So I think it really speaks to her integrity and the power that she had to film that, to bring light on that. They're 2 very pointed ends of the spectrum, I guess. And I think when we start to look at a population perspective and those challenges that people face in everyday services, if it's affecting their ability to actually go to a hospital, I'm encouraged that people are going to the hospital, but I'm particularly concerned about people who wouldn't go to a hospital or don't feel safe to go to a hospital. I think that's where some of this cultural safety work is really important. One of the other aspects I think is around the structural racism, essentially. So I think I spoke about the governance arrangement. I think that really helps, but I think one of the challenges with implementing some of the cultural safety training that we faced in North America is actually around implementation and how we can influence structures so that they do foster a culturally safe environment, as opposed to some of the other sort of short-term challenges that we might face. Noting it's not a binary challenge, it's there's more than one way to skin a cat, I guess. So a number of ways that we can address that. If you haven't read the Bringing Them Home report or the summary, I'd strongly encourage that, because I think it's always insightful and useful to reflect on where we've come from and where we're going. And I'd ask everyone, one of the exercises that we would do is whenever on public transport is to question your prejudice and bias. And so the exercise I do is when I'm on a bus or on the subway in Toronto, is to question why you might have certain thoughts or beliefs about a way someone might be dressed, the way they might walk, the way they might interact, and just think about where I come from and the views and the values and the beliefs that I bring to the table. I'd also encourage everyone to take a cultural safety course and to build Indigenous-led partnerships, creating safe spaces. So again, stressing the importance of having strong governance and leadership from the top down, but also at all levels. And then to finish, I think if I look at the last 5 years, so much work has occurred and so much work is continuing to occur that is creating safer environments, but there is a lot of work to do. Thank you.
Thank you, Raglan. And now it's over to Dr. Raymani. Over to you, Ray.
Yeah, thanks, Chris. Morning, everyone. Just give me a second to get myself organised. My sharing screen. So I hope that's okay. Can everyone see that?
Beautiful, right?
Okay, no, thanks. Look, it's a real privilege of mine to be speaking with everyone today. And Chris, thanks for the invitation. I'm with the CSIRO, and look, this is just a snapshot of what I'm going to cover. It looks like a lot of things, but I'll sort of work through, and slides will be made available. But really I want to talk about Indigenous status and how it's collected and the implications of the way it's currently collected, and some of those implications on healthcare and more importantly, health outcomes. And also finish off with some discussion around patient journey. But before I start, I'm just going to dwell on just for a second around CSIRO. That's where I work as a scientist. It's our agency. It's a big agency, and we have sites all across the country. I work in the health and biosecurity area, and we have a number of business units working across a range of fields that I'm sure most of you are sort of well aware of. My area is e-health, and I'm working across a range of e-health projects, looking at mobile health, our Smarter Safer Homes platform for supporting aged care, and thermal comfort for communities in Central Australia. We work closely with a number of Aboriginal and Torres Strait Islander organisations. Right, so my background. I'm Aboriginal. My people are Budjara people from Central West Queensland, and I acknowledge the traditional owners of the land that I'm talking to you today from, and that's the Turrbal and Yagara people here in Brisbane. My office is situated within the Royal Brisbane and Women's Hospital here at Hesta. My mum came from Central West Queensland. She grew up in Augathalla. We live in Wynnum, which is a bayside suburb in Brisbane, and I'm a director on the board of our local Aboriginal organisation, and we provide about 40 houses to our community, and we run a small aged care facility, about 24 beds for our community. Oh, can't go on without mentioning the most important people in the family at the moment, the 2 dogs. So what am I going to talk about? I'm going to talk about Indigenous status and then talk about some of these implications, but just a quick refresher. So Indigenous status, it's a mandatory demographic data item that's been in hospitals collected since 1996. And why do we collect Indigenous status? Monitor and report on service usage, measure and report on health status, monitor health outcomes, look at change over time, and it's actually used to allocate funding. So what's the question? It's based on the ABS question originally, which is, are you of Aboriginal or Torres Strait Islander descent? And how is it recorded? Well, in the hospital systems, it breaks down whether someone's Aboriginal, whether someone's Torres Strait Islander, whether someone's both, whether someone's not, or if they can't answer the question. But who is Indigenous? And this question comes up all the time. We have a legal definition for who is Indigenous, and that's made up of 3 components, and that's descent, identifying, and is accepted. And that came out of a High Court decision in 1983. And there's a whole history to that, which I won't go into. But importantly, while that's about how we define who is Indigenous, in these settings, who decides if someone is Indigenous is the patient. In administrative data sets, it's not about determining if someone's Indigenous, it's about the patient or whether it's a school student giving the option to choose to identify, and it's something that shouldn't be challenged or questioned. And it's really important to keep asking the question, because people, as you kind of obviously understanding from my 2 previous presenters, is that people may choose not to identify as Indigenous because of concerns, amongst other things, around treatment and racism. So that's a quick snapshot. But importantly, what's been the history? In 1955, there was reported by NHMRC, there was no means to measure what was going on with Indigenous people. And I've just put that slide up, the graph up there from the Medical Journal of Australia. I'll come back to that in a second. First collection was in Northern Territory, infant mortality. Then we had states started to adopt policies around collection. And then in 1984, all jurisdictions actually started implementing procedures. Notably, of course, Queensland didn't do it. Queensland continues to be an outlier in many things, in particular around how we as Aboriginal and Torres Strait Islander people are treated in this state. And AOHW were handed control to coordinate the collection, because even, like, that's only 35 years ago, we weren't able to provide any real data on Indigenous health. And then AOHW were funded to do this work. And then finally in 1996, we had the Indigenous status data item included into hospital collections consistently across the state. So that's not long ago. And prior to that, we were, we really didn't have good quality data. Not that to say current data is that great a quality either. But I put the MJA report up there as just a reminder that, even the medical field over our recent history purely focused on observational research largely, and at the cost of not wanting to conduct more interventional studies, and even considered a moratorium on publishing research. It's a reflection of a past history where Aboriginal people were observed and those things, and medical profession didn't intervene. Anyway, where we are today, which is fantastic, we've got our standards, and importantly, there's a specific set of standards around collecting Indigenous status, and it's linked to, not just stands on its own anymore, it's linked to other really important policies and changes that hospitals need to make. So that's a fantastic step forward. But, we don't know right now what the impact of these changes have been. So how accurate is Indigenous status? There's been a number of studies over the years, and AOHW have a specific methodology for assessing the accuracy of Indigenous status. And it involves simply having, the gold standard is having a trained interview go around bed to bed over a day or two and interview each patient and ask the Indigenous status question. And then you sit down in medical records and compare that result to what was recorded at admission, right? So the findings of these studies over the years, I've seen it around 90% accurate, which I guess doesn't seem that bad. And I've circled how many Indigenous patients were involved in the Queensland patients were involved in the last big study administered by the AOHW in partnership with each jurisdiction. Because in my thesis, I implemented an alternative methodology with a cohort of 294 patients, some non-Indigenous, but 231 Indigenous. And the results were quite different, with only not even 60% of Indigenous patients accurately recorded as Indigenous in the hospital system. So it sheds some sort of light or question on how accurate Indigenous status is recorded. So what are the implications of it? And within the AOHW, you can look the reports yourself. They talk about completeness and correction factors, so that you're able to, hospitals and health services and the governments are able to correct the actual numbers to come up with a more accurate picture. And applying the findings from my study, which shows us that we're potentially missing many, many thousands of Indigenous hospital separations because people aren't accurately identified. And so that, going back to my slide about why are we collecting it, then that sort of has implications on how the data can be used to monitor health status, how funding's allocated, and those sorts of things. So that's a challenge. But look, more importantly, what's the association with cultural safety and culturally safe care? Collecting Indigenous status isn't, we can't look at it as just this sort of standalone process or procedure. It actually has quite significant implications. And looking at some work around cultural safety, and if we look at systemic, organisational, professional, individual levels, and we look at Indigenous status identification, we see that for Indigenous people, they may or may not be willing to identify because of past experience or fear of substandard care. Non-Indigenous people coming to hospital should be asked the question every time, but if the reaction is one of sort of has racist overtones, the people collecting it are reluctant to ask everyone. And then if the hospital systems aren't geared and the policies and procedures around collection, then that has further implications. And casting a view over all of this is what's going on in society, which our other two speakers have talked about, racism and bias that's within society that impacts on people providing care. So looking at a particular area, cardiovascular disease, which is where I've done research, what's the implication around cardiac care? We know that Aboriginal and Torres Strait Islander people have received the lowest standard of care compared to non-Indigenous patients, and I'll come to a slide with that. But it can be attributed to a range of factors, not just racism, but a range of factors. And I'm not going to sort of dwell on this, but needless to say, there's substantial evidence to show that if you're Aboriginal or Torres Strait Islander and you present at hospital, you're less likely to receive the same diagnostic procedures and tests and have a less positive outcome, sadly. But it's not that simple. CBD care is very complex. And there's a whole range of different clinicians and hospital people and community involved in care. So there's numerous opportunities for racism. But those various opportunities or events can impact on standard of care and the patient journey and ultimately health outcome. What we've seen in the literature is, and if we go back to the comment earlier, the talk earlier around cultural blindness, we even see in the literature when people who have studied this and published, they sort of start to present excuses, if you like, for poor hospital care. If you like, directly or indirectly, if you like, blaming an Indigenous patient for the outcome, citing things like poor health literature, lower levels of education, competing personal and family demands, cultural misunderstandings, transport issues, financial constraints, being more mobile, and fear of hospitals. So some of these sort of terms, I know I'll be ringing true to many of you out there who are listening, but instead of the hospital and health systems and cardiologists and the people involved in researching saying, well, maybe the problem is with the system, it's easier to blame the patient. And a lot of these reasons that have been put in the literature are reinforcing, sadly, these very negative stereotypes. So I looked at patient journey around cardiac care, and I found a few things. Indigenous patients were less likely to have a medical review at admission. They're less likely to be screened for CVD risk factors and less likely to have a follow-up appointment compared to their non-Indigenous cohort they were with. But, we need to consider that there's other factors, like I said before, about complexity. So there's longer lengths of stay have an impact. And because the cohort came from rural and remote Queensland, there was support provided by Queensland Health around transport. So they're the kind of unique aspects that we need to consider with Indigenous patients. So in conclusion, my key points are that collecting Indigenous status is often the first step in a patient journey. And it happens at multiple steps in a patient journey, all right? People are, they go to different clinicians or they go to different parts of the hospital and keep being asked similar sorts of questions or same questions. And often the Indigenous status question might be asked a number of times. So it raises the question, does asking Indigenous status reinforce racism? Across the whole system, internalised, interpersonal and systemic. Bearing in mind the concerns of the individuals asking the question and their own internalised racism. And so is asking Indigenous status another form of racial profiling? Considering the short history of collecting it, and so maybe we should be focusing on collecting Indigenous status and reporting it within the confines of culturally safe clinical care, rather than sort of at the outset or the beginning of that trajectory patient journey, which potentially creates, has a flow-on, can have a flow-on effect on that patient's experience. And we know health services are capable of providing culturally safe care to Indigenous people. The cohort I worked with for my thesis received care out in remote and rural Indigenous cardiac clinic, and they were receiving above the recommended standard of care while they were being treated by the same white cardiologists, but in a proper culturally safe setting. It's when they came to a public hospital, large tertiary hospital, that their care trajectory changed. And it's really important, accuracy of Indigenous status, because we're really there's some real gaps, I think, in having good quality health information. And look, one of the most challenging aspects of it is that systemic racism, it requires a lot of attention. I mean, unless we can tackle systemic racism, it's going to impact on our capacity to provide culturally safe care. And we want culturally safe care to become normalised in our hospitals. So that's a quick snapshot for me, and I'll hand back over to Chris. So thanks.
Thank you, Ray.
I just have to stop.
That was a great presentation. Now I'm just going to start off with some Q&A. So over to a question first to Alyssa. Alyssa, in that development of that quantifiable measure for cultural safety, that's really interesting because numbers are so powerful. They're so powerful. Do you think there's the potential with the tool that you developed for regional or jurisdictional variation? And how would you go about that? Would you be using a co-design process, perhaps?
Yeah, absolutely. That's a fantastic question. And it's actually something that I'm working through at the moment. I think there is scope to use, but obviously modifying the tool for specific communities and regions. And I have had quite a few inquiries from health services in different states and different types of health services as well. So within primary care networks as well, so in GP practices, but also with hospitals and also with Aboriginal community controlled organisations, which I think would be an interesting exercise to see, those differences in cultural safety. But yeah, there's definitely scope for that. It's something that I'm really interested in. So if there's anyone out there that would like to do that with me, yeah, please let me know. But yeah, there's definite applications outside of New South Wales.
Thank you, Alyssa. A question for you now, Ray. That influence of racism on the journey of Aboriginal and Torres Strait Islander patients through hospitals and mainstream health services seems really strong, and especially when they identify. That really seems to be counterintuitive, doesn't it?
Yeah, look, that's one of the startling things, that identifying and declaring as a patient you're Indigenous, you would hope that or expect that your standard of care then in the trajectory, should reflect your specific needs. But sadly, we're trapped in a society where racism is so embedded and unconscious bias. And I know Alyssa talked about her findings, and they're the people who are entrusting. Well, I'm entrusting my mum and my family to, and they're holding those views that are spread across society. So we can't assume that just because someone goes to work and puts on their lanyard as a doctor or a nurse or a health worker that they're not racist anymore. That they're not going to have their own unconscious bias or their own sometimes not unconscious bias impact on in their own personal stereotypes. And this is our challenge, and we need to see more leadership shown to help combat racism in society.
Thank you, Ray. And now a question for you, Raglan, with that North American and specifically Canadian perspective that you brought. Can you able to tell us a bit more about how Canadians are tackling racism in healthcare? And maybe you could talk about some examples if you're aware of where that may be successfully dealing with institutional racism, which of course provides the environment for all these other things to brood in, for that interpersonal racism, that lack of cultural safety, and of course then pushing back onto us as Aboriginal and Torres Strait Islander people here in Australia, that internalised racism, where we start to sort of believe what people are telling us.
Yeah, great question, Chris. I wish I had all the answers. Obviously, there's no silver bullet to this, and we do need to take a multi-pronged approach. Yeah, there's some interesting, I guess it's also useful to consider the intent with the way that some people are trying to address racism. So I guess the first part, I think the truth and reconciliation process is really important. I think trying to accept the truth and recognise that this is an issue that we are facing on a day-to-day basis is really important. Starting with schools and education, and yes, it's getting better, but yes, we have a long way to go. An example I can think of that I'll be interested to see how it pans out, and somewhat sceptical, is the Ontario government set up an anti-racism directorate to challenge racism, particularly Black and Indigenous people. Again, driven by government, top-down approach, not necessarily with the voices of Indigenous people, in a healthcare system or in a system where there is a lot of risk that comes to enforcing that sort of approach. So I guess I'd tread cautiously there. I think we can probably learn a lot from, in Canada, they have Aboriginal health access centres similar to the ARCHOs, and there's a lot of work that is going on in that space to improve care. One of the things Elisa spoke about was, she spoke about a mother not being able to support her daughter, I think, or a client. And so trying to change that is quite useful. So an example I can think about is 7 Generation Midwives Toronto actually built a clinical facility from the ground up on Indigenous knowledge, ways of knowing and doing. And that is within the infrastructure of not just the governance, but the actual physical building. So they've used materials for the floor that look like the ground in Toronto. They reflect the wood, the cedar in the walls. They have water, they have fire, they have a kitchen where you can, outside of the birthing centre, you can come out, and the first thing you can have is you could have a drumming ceremony, and you can have a kitchen, and you can have all the family community. You can have smudging, so similar to sort of, but completely different, obviously acknowledging the diversity of Indigenous people, but smoking type ceremonies. So the actual infrastructure is there to create safe spaces as well as other supports. And that also speaks a little bit to bringing country to a birthing centre. So not just birthing on country, but the other way around as well. God, that's, I can't even remember the second prong of your question there, Chris. Sorry to start ranting on.
That's all right, Ray. We're just about to run out of time. So we've got a great question or a question and a comment here from Mandy Trong. Leadership and commitment is important for driving change. How do you think we can get executives and management in the health system to have honest and open conversations about racism? And first in, best dressed to answer this one. Raglan?
I thought, I think overnight success doesn't come slowly, but I think there's a lot of good things that are happening, to be honest. I think the Voice to Parliament, looking at various calls from Indigenous leaders and elders around ways that we can improve. I think also local governance arrangements that seem to be working really well. And again, leaning on AMSs and others that have really set the precedent for access to services and other things. But I was going to defer to the other experts on the panel, to be honest. I feel like I've talked a lot.
I can see Ray's keen to say something there.
Oh yeah, look, very, very quickly. Look, that's one of our big challenges. And look, I think the only advice I can give is that people at those really high levels need to sort of own the decisions and be part of the process. And I see a tendency to devolve responsibility. Like if you have your Indigenous executives within the system, now it's kind of like, well, I've done my bit. It's over to that person. And then the onus is on us as the people in those senior positions to take our executives on that journey and coach them and give them the permission to share the responsibility of cultural, and systemic change. So it's not always fallen onto us to do all the heavy lifting. That's my comment. But it's...
Yeah. Well, thank you, Ray. And I absolutely agree that dealing with institutional racism in organisations is the work of boards and CEOs, and that those ground-up approaches can be advocates for change, but this is top-down work. Thank you to all our panellists for your participation today and your contributions. For the participants, if you're interested in finding out more about the work of AHHA, please see our website at ahha.asn.au. And thank you to Neil and Hesta for your sponsorship for today's event. Thank you all, and have a great day, and happy NAIDOC.